Hi, and welcome back to part 3 of our 3-part lecture series on critical care medicine. I'm Josh Lumbley. Let's go ahead and get started. So we're going to talk about 4 sections for this third lecture. We're going to talk about respiratory failure, auto-PEEP, sepsis, SIRS, multiple organ dysfunction, and then finally I'm going to hit some high points, some miscellaneous topics that oftentimes present on the exam. For the next 15 or so slides, we're going to talk about respiratory failure, ventilator-induced lung injury, ARDS, talk about protective lung ventilation, and the concept of auto-PEEP. Question: which one of the following has not been implicated in the genesis of lung injury related to mechanical ventilation in patients with acute respiratory distress syndrome, or ARDS? A. Overdistension of terminal respiratory units. B. Release of inflammatory mediators by atelectatic lung segments. C. Impairment of mucociliary clearance. D. Nitrogen toxicity. Or E. Profibrotic factors produced in atelectatic lung segments. And the answer here is D, nitrogen toxicity. We're going to spend a lot of time talking about ARDS in these subsequent slides, but it's just important to note that nitrogen toxicity is not seen with ventilator-induced lung injury. So ventilator-induced lung injury, at the macro level, it's associated with barotrauma and elevations in peak pressure, which can give you pneumothoraces, pneumomediastinums, as well as subcutaneous emphysema. It's associated with volutrauma, so you get alveolar overdistension, specifically in the apices, and then there is a recruitment and collapse phenomena as more ventilation is shunted or distributed to the apices of the lungs, and the base of the lungs are relatively underventilated. Oftentimes, it is associated with oxygen toxicity, so using super high FiO2s, mucociliary dysfunction. As you have oxygen toxicity, you have atelectasis, you have worsening clearance of secretions, then of course you get ventilator-associated pneumonia, and then finally, due to this elevation in tidal volumes and hyperinflated lungs, you get worsening hemodynamics, which are caused by the positive pressure ventilation itself, the use of PEEP, which impairs venous return, and then finally, in order to get a patient to tolerate the endotracheal tube and being on the ventilator for an extended period, you're using sedative agents which cause vasodilation and worsen cardiac output. So ARDS, acute respiratory distress syndrome, has been around for a while. In 1994, there was an extensive set of definitions that were attached to it in the diagram here. I'm not going to go through all of these, but what you need to recognize is it's consistent with bilateral pulmonary infiltrates. You've got a PA2 over FiO2 ratio of less than 200. Do recall that acute lung injury is a PaO2 to FiO2 ratio of less than 300. And of course, you've got to be able to exclude cardiogenic pulmonary edema. So this is utilizing various clinical criteria to exclude cardiogenic causes and rule in ARDS. So we're looking for a pulmonary capillary wedge pressure of less than 18, which will shift us away from a cardiac cause associated with this respiratory syndrome. So in Berlin, the Berlin definition, which is fairly recent from 2012, we look at a proximity of around a week from a clinical insult, whether that be aspiration or pneumonia or a chest injury. You're going to look for bilateral opacities, origin of edema. So respiratory failure that cannot be explained by a cardiogenic cause or volume overload. And then again, we're looking for a PaO2 or FiO2 ratio of less than 200. Certainly severe, less than 100 is known to be quite poor. So with ARDS, hitting this home again and again and again, cardiogenic pulmonary edema has to be excluded before you can rule in for ARDS. So you got to look at the clinical criteria. You've got to evaluate the patient's heart. You may have a swan in place that you're looking at left side function of the heart. So BNP, if it's less than 100 brain natriuretic peptide, that typically is going to favor ARDS and exclude it from cardiogenic causes. If you have a super elevated BNP, you might be apt to rule in a cardiac cause. If it's slightly elevated above 100, you can't confirm it or exclude it. Echocardiography, look, do we have an LV that's functioning, that's working well? Is it hyperdynamic, etc.? And then, of course, the pulmonary capillary wedge pressure as an assessment of how the left side of the heart is functioning. It's got to be less than 18. Question: which one of the following is most correct concerning the potential for overinflation lung injury or volutrauma during mechanical ventilation for acute respiratory stress syndrome? A, with ventilation settings held constant, the risk for ventilator-induced lung injury decreases as dependent atelectasis and consolidation increases. B, with ventilator settings held constant, the risk of ventilator-induced injury increases in the presence of an edematous chest wall. C, the primary goal of preventing ventilator-induced injury is to maintain transalveolar distending pressure equal to or less than total lung capacity in the normal lung. Or D, the highest pressure in the ventilatory system during inspiration is the key variable predicting risk of ventilator-induced lung injury. Give you a second to work through those answers. Excuse me. Okay, and the answer here is C. The primary goal of preventing ventilator-induced injury is to maintain transalveolar distending pressure equal to or less than total lung capacity in the normal lung. So the risk for injury is going to increase as atelectasis and consolidation increase. An edematous chest wall is actually going to decrease compliance, and if using a pressure-supported mode or even a volume-supported mode, we're going to have decreased tidal volumes. So the key variable for predicting risk of ventilator-induced lung injury is plateau pressure. So we have seen this image over and over again in our respiratory lectures. We're going to go over it again here because you can't see it enough. So obviously we have 3 west lung zones, zone 1, zone 2, zone 3. In the normal lung and west lung zone 1, we see that our alveoli are open due to the pull of gravity from the lower segments of the lung. We see relative normal ventilation and perfusion in the middle of the lung, and then in the base of the lung, due to gravity compression, we see perfusion continuing, and we see a relative shunt down here as perfusion exceeds ventilation, and we see slightly compressed alveoli. In the damaged lung, as consistent with ARDS, we see our alveoli go from this size here, to actually larger as the lung is heavy, wet, and boggy. So we have over-distended alveoli in the apices of the lungs. We have a much smaller window of therapeutic index, if you will, in the zone 2 region. And we have a larger zone 3 region due to excess fluid. And so these alveoli go from being already somewhat collapsed to total collapse. And we get a frank shunt in the base of the lung. So again, The increase in pulmonary water, it's going to dilute surfactant, it's going to decrease or increase surface tension, which is going to increase stretch and overdistension in the apices and increase collapse and underdistension in the lower reaches, or in West Lung Zone 3, which is only going to further in this vicious cycle of worsening ventilation and perfusion. So what we see is that the best correlative measure for transalveolar pressure is the plateau or P pause to measure alveolar distension. So what we're looking for is a period where there is no increase in volume, where we see our flow goes to a zero flow state, and we see pressure held constant. And that is consistent with plateau pressure. Now, protective lung ventilation, there's a whole host of literature out there about the need, not just in patients that have ARDS, but in lay patient population that are intubated, to use a protective lung strategy of low volumes, but also the use of PEEP. So what we're looking for is tidal volumes of 7 mLs per kilogram, ideally even closer to 5, and with ARDS, 3 to 5 mLs per kilogram. We want to bring down our FiO2 as much as possible. So with ARDS, our goal is a PaO2 of greater than 55 or saturation of greater than 89. We want to utilize PEEP aggressively in an effort to open up these alveoli in the base, and also to keep us from going back to increasing our FiO2. We allow permissive hypercapnia in these patients because, again, oftentimes we're going to be using such low tidal volumes that we're not going to be able to get off all of our PaCO2. So we allow permissive hypercapnia, and we may in fact allow a relative respiratory acidosis. A pH of our goal pH is anything greater than 7.2. Exception, of course, is if you have elevated intracranial pressure, in which case acidosis is actually going to worsen that intracranial pressure. We want to manage our fluids, so we don't want to make them volume overloaded. We don't want to take an ARDS type scenario and worsen it with a cardiogenic shock or volume overload type scenario. Okay, for the next 10 slides, we are going to talk about auto-PEEP. Which of the following statements is most correct concerning auto-PEEP in the mechanically ventilated patient with obstructive airway disease? So we're going to assume volume ventilation. A, as a patient progresses into a state of auto-PEEP, equilibrium is typically achieved by a decrease in ventilator-delivered tidal volumes. B, the optimum treatment for auto-PEEP is to increase the inspiratory flow rate. C, in the spontaneously breathing patient, auto-PEEP is best diagnosed by a prolonged end expiratory hold. Or D, the use of flow triggering is a mechanism to decrease work of breathing in the spontaneously breathing patient being mechanically ventilated with significant auto-PEEP. You may want to press pause to work through these answers. But the answer here is D. The use of flow triggering is a mechanism to decrease work of breathing in a spontaneously breathing patient being mechanically ventilated with significant auto-PEEP. So decreasing tidal volumes, that's really not going to affect auto-PEEP. So the optimal treatment of auto-PEEP is going to be prolonging the expiratory time. It's not diagnosed by an expiratory hold. And by using flow triggers, the patient can decrease his or her work of breathing and reduce the risk of breath stacking. So what we see with auto-PEEP is breath stacking. So in this case here, we see exhalational flow that is continuing while inspiration commences. So we see expiratory flow, and we see inspiration that's actually beginning before the patient is fully expired. So we see breath stacking. What happens with breath stacking? Well, the lungs cannot fully recoil, and therefore you get decreased cardiac output. and hypotension. And as these breaths do not completely recoil and they get more full, you have an increased risk of barotrauma, which can induce pneumothorax. Other tests for auto PEEP and breath stacking is using the end expiratory occlusion pressure, looking at an esophageal balloon, and then a prolonged end expiratory hold. This, of course, does require a passive patient, so they've got to be intubated and be able to tolerate this, because a prolonged end expiratory hold is not an enjoyable process to go through. So, compliance curve, and not surprisingly, these match up with the West lung zones. So what we see in West lung zone 1, we see a small increase in pressure a small increase in tidal volume corresponds to a massive increase in pressure. So these are already fully dilated alveoli. So these are overexpanded lungs. At the normal part of the curve, so West lung zone 2, we have a small increase in pressure corresponds to a large increase in tidal volume. So we have alveoli that open very easily and are responsive to ventilation very, very easily. So there's good recoil and there's not a whole lot of work of breathing. And obviously at low FRC, it is challenging to open those alveoli. So to get a small tidal volume, you see a large increase in pressure. So you have to apply a great deal of pressure, a breath hold, PEEP, hold down your bellow or your bag, flip the patient to manual ventilation, hold the bag down with sustained pressure to open these alveoli that are in West lung zone 3. So again, low response of tidal volume to a large response in pressure, relatively lower response in tidal volume to a large increase in pressure, and at the optimal portion of the lung, you apply a little bit of pressure and you get a significant improvement in tidal volume. More recoil, more work. At equilibrium, airway distension equals the closing volume or dead space. So the more recoil you have, or increasing lung recoil, depends on where you are on the compliance curve. Obviously, we talk about that sweet spot right in the middle. In West lung zone 2, you see a significant increase in tidal volume responsive to a small increase in pressure. For spontaneous breathing on an endotracheal tube, the patient has to overcome both the demand trigger as well as auto PEEP. So they have to be able to pull back on the endotracheal tube, trigger the machine to say this patient is breathing, and they've got to overcome auto PEEP. So in order to decrease work of breathing, what we want to do is minimize the difference between the PEEP that we utilize to keep the alveoli open and the auto PEEP that the patient has this propensity to develop. So what we're doing here is allowing flow triggering, or we're shifting to more of a pressure supported ventilation type phenomena. So our treatment for auto PEEP is going to be, we want to prolong that expiratory time. We want to lengthen the amount of time that that patient has to exhale. So when we allow for an increasing expiratory time, oftentimes the response is going to be, we need to decrease our respiratory rate, we need to decrease our tidal volume, if we increase flow, that just means we're hitting the lung with higher flows. We're trying to get the same amount of tidal volume in a smaller inspiratory window. And where does that air go? It goes to already inflated areas of the lungs that have relative dead space ventilations in the apices of the lungs. So that's why we advocate for decreasing tidal volume, decreasing respiratory rate in order to allow for a longer expiratory time, understanding that there's going to be some permissive hypercapnia that you've got to tolerate. A 35-year-old male is admitted with severe bronchial asthma requiring ventilator support. He is fully sedated and paralyzed on assist control mechanical ventilation with a set rate of 15 breaths per minute, tidal volume of 1,000, inspiratory flow rate of 60 liters per minute, and that gives an I to E ratio of 1 to 3. He's not on any PEEP, and an end expiratory hold maneuver reveals an auto PEEP of 15 centimeters of water, so not good. Which one of the following options is likely to be most effective in minimizing the auto PEEP? A, decreasing the respiratory rate to 12 and giving an I to E ratio of 1 to 4. Increasing the flow rate to 120 liters per minute, giving an I to E ratio of 1.7. Decreasing the tidal volume to 900. Adding external PEEP of 5. Changing the square root delivery pattern to a decelerating mode. Okay, and the answer here is decreasing the respiratory rate to 12 and giving an I to E ratio of 1 to 4. So I to E ratios are percentages. So we're going to do a deep dive into A, B, and C answer choices. We're going to exclude D and E because those really aren't germane. So all we're really thinking about is what can we do to the ventilator? Decrease the rate to 12, give an I to E ratio of 1 to 4. Increase the flow rate to 120, give an I to E ratio of 1 to 7, or decrease the tidal volume to 900. So we see those answers kind of match up. 12, respiratory rate stays at 15, 15, 1,000, 1,900, I to E ratio of 1 to 4. Okay, and we see what happens to the time of inspiration and time of expiration. And, the most important thing here is we're trying to decrease auto PEEP. And so in order to decrease auto PEEP, as we've already established, we need to expand the expiratory time period. So by decreasing respiratory rate to 12, that's 1 breath every 5 seconds. We did not change anything on these. 1 breath every 4, 1 breath every 4. Therefore, our time of expiration, while it is expanded somewhat with a tidal volume of 900, and is expanded somewhat by increasing our I to E ratio with a flow rate of 120, we see our time of expiration is 3.1, 3.5, 3. The one with the largest, of course, is decreasing our respiratory rate to 12, not touching anything else. Expanding our I to E ratio of 1 to 4. So in that case there, that's what makes A the correct answer, is it most effectively expands that time of expiration. All right, we're going to shift gears and hop into sepsis, SIRS, multiple organ dysfunction for the next 6 slides. What is the difference between septic shock and severe sepsis? A, septic shock is characterized by a temperature higher than 39 degrees Celsius. B, only severe sepsis is caused by an infectious cause. C, only septic shock demonstrates end organ failure. D, severe sepsis must have a heart rate of greater than 120, or E, septic shock is defined as severe sepsis that is refractory to adequate volume resuscitation. And the answer here is E. Septic shock is defined as severe sepsis that's refractory to adequate volume resuscitation. So both severe sepsis and septic shock, you can be hyperthermic or you can be hypothermic. Both are characterized, in order to be sepsis, they've got to have an infectious cause. They both demonstrate end organ failure or dysfunction. Typically 120, that's bad sepsis. When you think about sepsis, you're looking for a heart rate elevation of greater than 90. And then finally, septic shock is severe sepsis that's not responded to volume resuscitation. So what is sepsis? It's a systemic response to an infection that's characterized by some portion of the following. If it's really bad, it's going to include all of it, but it may include just some portion of it. So your relative hypotension, so SPP of less than 90, some mental status change. Patient may or may not have a PaO2 of less than 60 or a demonstration of acute lung injury, which is a PaO2 over FiO2 ratio of less than 300. Increased lactic acid or lactic acidosis, oliguria, DIC or a platelet count of less than 80, or an elevation in liver enzymes greater than 2 times normal. So what is the relationship between SIRS and sepsis? So SIRS is systemic inflammatory response syndrome, and SIRS response arises from 2 or more of the following: temperature greater than 38 or hypothermia less than 36, tachycardia, respiratory rate of greater than 20, white count of greater than 12,000 or less than 4,000, or the presence of greater than 10% bands. So in order to have SIRS, we're going to follow down with this terrible pathway down to septic shock. So you start with SIRS. You may have 2 or more of those below. Now, if you have SIRS in the presence of an infectious cause, now you have sepsis. If you have the presentation of sepsis with organ failure, that is defined as severe sepsis. If you take a patient with severe sepsis and you try to give them IV fluids and volume resuscitate them, and they are still unresponsive and still have hypotension, that is considered septic shock. Now, what is multiple organ dysfunction and its relationship to SIRS? So SIRS, systemic response to a variety of insults. It can be infectious or maybe not, but it can also be ischemia or injury, and that leads to a multitude of ill effects in circulation and organ perfusion. With multiple organ dysfunction, that's the presence of an altered organ function in an acutely ill patient that has SIRS. And you have to have some external intervention to improve the underlying condition that's contributing to the multiple organ dysfunction. So with SIRS, we talked about it being infectious. That is sepsis. You can have an injury. It could be transfusion reaction, or it can be an inflammatory disease like lupus. Now, if SIRS gets bad enough, and you get vasodilation, you get tissue edema, you get dysfunction of the CNS system, you get cytokines, TNF-alpha, etc., which worsen this inflammatory response and vasodilation, you're going to get altered organ function. If you do not intervene on this patient with whether that be warming, cooling, application of an anti-inflammatory, giving blood, or antibiotics, whatever it may be, then you will go from MODS to frank organ failure and frank organ death. All right, miscellaneous. I'm going to just hit some high points that fit in well with the critical care portion of the lecture. These commonly appear on the exam as sort of one-off questions. The most common cause of needle stick injuries is A, failing to double glove with known seropositive patients. B, use of straight needles for suturing. C, improper disposal of sharps. D, recapping of needles. E, failing to see the needle exit site during suturing. And the answer here is D, recapping of needles. So in a patient that is seropositive, what we're going to want to do, patient of course needs to be, we got to test the worker, get a baseline of do they have HIV, do they have a hepatitis B, and hepatitis C. We've already established that the patient has HIV, HBV, or hepatitis C. All right, and then based on the risk, if it is a hollow bore needle, if it's a large gauge needle, if there is blood content in the needle, etc., we may need to start post-exposure prophylaxis. It's not necessary in all cases, but based on risk, we may need to. The greatest number of needle stick injuries occur from trying to recap a needle. That's followed closely by improper disposal of the needle. The risk of seroconversion from a known positive source with a needle stick. Now again, the risk falls on a spectrum based on, is this a large gauge needle that's got blood in it? Is it a hollow needle, etc. 5 to 10% seroconversion for hepatitis C, 2% for hepatitis, 5 to 10% for hepatitis B, 2% for hepatitis C, and 0.3% for HIV. Okay, I know that you have been exposed to toxins, poisonings, and the antidotes with previous lectures, so I'm not going to do a deep dive on this. But what you need to remember when a patient is exposed to toxins is immediately stabilizing that patient. So that means assessing the ABCs. So you look at this as A, B, C, D, E, F. So ABCs, and then you want to decontaminate the area. You may want to give this patient ipecac, gastric lavage, bowel lavage, charcoal. You're trying to decontaminate the presence of the agent that's in either the bloodstream or gastric contents. Then you want to focus on enhancing elimination. So giving multiple dose activated charcoal, perhaps alkalinizing the serum to cause ion trapping and avoiding deposition of these toxic drugs or toxins in the peripheral tissues. And then lastly, you may want to consider hemodialysis. And then finally, the F is find the antidote. If an antidote exists, give it. I have a variety listed over here. I'm not going to go through all of these, but these you need to memorize for the exam. There are some really high yield ones: acetaminophen, organophosphate, methemoglobinemia, and ethylene glycol. Those treatments, you need to know those. And that is it. So this is the third of the 3 lectures on critical care. I really appreciate you being with us for this critical care journey. Thank you so much.